So our last speaker for the sessions this afternoon is Dr. Anna Suller-Marti, and Dr. Suller-Marti is an assistant professor in the Department of Clinical Neurological Sciences at the Schulich School of Medicine and Dentistry. She earned her medical degree at the Universidad de Valencia in Spain and completed her neurology residency at Hospital Lozana Blesa in Spain, then completed a one-year fellowship specializing in headaches at the Hospital Clínico de Valencia in Spain. And she acquired her master's degree in medical research at the Universidad de Zaragoza and continued to complete her PhD program. Currently, she has been at Western since 2018 when she completed a two-year clinical fellowship and one-year research fellowship specializing in epilepsy. She is a member of the newly developed Transition Epilepsy Clinic team. And her session this afternoon is entitled Epilepsy, More Than a Comorbidity for Patients with Intellectual Disability. Thank you.
Thank you so much for inviting me to present today. I was really pleased to listen to the previous presentations and learn more about something that is not my main topic. So the topic of today is epilepsy more than a comorbidity for patients with intellectual disabilities. So I don't have any conflict to disclose regarding my presentation today. And then the agenda for today, it's a bit busy. So we have start with understanding the nature of epilepsy and the epidemiology of epilepsy in people with intellectual disabilities. Then I would like to try to put the sets, how to learn about how we can diagnose patients with epilepsy and intellectual disabilities and the challenge that we face, as well as discuss the best management practice for epilepsy in this population. So starting from the beginning, this is a bit out of normal area. So I will talk about epilepsy, that it's also a common neurological disease that affects 1% of the population. And epilepsy is the disorder that is associated with the predisposition to generate seizures, but also the neurobiologic, cognitive, and psychological and social consequences associated with seizures. So epilepsy need to be distinguished than seizures. Epileptic seizure is the transient occurrence of signs and symptoms due to the abnormal or excessive synchronous neural activity, and is different than a seizure. Seizure is just the event, and then epilepsy is the disease that suggests to have a recurrent seizures. So moving on, the International League Against Epilepsy defined epilepsy as at least 2 unprovoked seizures separated by 24 hours, and one unprovoked seizure, and the probability for further seizures similar to the general recurrent risk, at least 60% after 2 unprovoked seizures, occurring this over 10 years. Or the other possibilities, the diagnosis of epilepsy syndrome. These definitions get changing every year, every few years, just to make the things a bit more complicated. But this is where we are right now. So moving on, when we talk about epilepsy, we need to talk about seizures. So seizures, we classify the seizure depending the symptoms or the signs that we see during these events. And then we can classify in 3 main groups. When we see focal signs, or we call focal onset, we see that it's more generalized of what was called in the past generalized tonic-clonic, grand mals, or even petit mals. They were classified as a generalized onset. And then when we don't know the start, we call unknown, and then try to, with other tools, try to learn how these seizures start and be able to classify. So, for example, in focal seizure, we also can use focal aware or unaware if they are not conscious during these episodes, or there is some motor or non-motor involvement. But this is kind of the basic, and then we can move to a more complicated, and I don't think today is the day to go to all the details about the type of seizures and how we can classify. So depending of this focal, generalized, or unknown, we can go a bit more in detail. That generalized seizures, usually it originates with a point that rapidly propagates to the rest of the network. Sometimes it's all at the same time, sometimes it's really fast that we cannot pinpoint. And these affect the cortical as well as the subcortical structure, but doesn't need to affect the entire cortex to call this is a generalized seizure. And then in the other side, we have focal seizures. These focal seizures are usually originated with a limited network or limited area, And this can stay there or can propagate to the same lobe, or even can propagate to the contralateral side or even to the rest of the brain. So these are kind of a picture of how we can know how the seizures navigate or flow through the brain. So we use this classification of seizure to help to define the type of epilepsy that we are facing. So usually if the patients have focal onset seizures, they have focal epilepsy. If they have generalized onset seizures, they have generalized. Unfortunately, some of our patients combine generalized and focal, and they have their own category as well. When we don't know the onset, we will go to epilepsy of unknown, pending to be a further investigation. And then moving on, we have the type of seizure, type of epilepsy, and then we try to classify depending of the etiology. So we say that it's structural if they have a tumor or a lesion, genetic, any underlying genetic abnormality, infections, metabolic, immune or unknown. Unfortunately, almost 1/3 of our patients, we don't know why they have epilepsy. And then when we have a different characteristics and they can fulfill the criteria of syndromes, they have the epilepsy syndromes. And then we can never forget about the comorbidities associated with epilepsy. So moving on to the epilepsy and intellectual disabilities, just setting a bit the base that probably everyone more or less know about this, that there was a survey done a few years ago, and from the 136,570 who complete these surveys, over 15%, over 15 years old, at least they have at least one developmental disability. And this developmental disability represents 3.2 of all the disabilities, and 3.8 of this population were 65 or older, and the prevalence of patients with developmental delay increased from 2001 in almost 14%. So if we go in deep to the epilepsy and intellectual disabilities, 1/3 of patients with epilepsy have intellectual disabilities, and if we move to patients with intellectual disabilities, half of them, they will have also epilepsy. An interesting study published in UK that reviewed 354,000 adults and children. They found that 374 had intellectual disabilities, and 18% of them, they associate epilepsy. And 92% of these start with epilepsy at childhood. So a similar study done in our center found that the prevalence of epilepsy and cerebral palsy was 1.1 over 1,000, epilepsy and intellectual disabilities 1.117, and epilepsy and learning disabilities was 2.58 over 1,000. So unfortunately, the prevalence of epilepsy and intellectual disability is pretty high. As previously mentioned, there are some variation of the numbers, but from 26 to 70, Marini and McDermott published that the rate was around 32 to 40%. Unfortunately, also in this population, as more severe the intellectual disability, more frequent seizures, and more refractory to medication, and many of them, they don't respond to anti-seizure medications. As we can see in this table, as more, if we consider all the types of epilepsies, in cases with more severe or profound intellectual disabilities, 55% is almost over 0.5% of these patients, they don't respond to anti-seizure medication. If we go to the type of focal epilepsy, 44% of them, in cases of more severe intellectual disability, won't be able to respond to anti-seizure medication. So as I start the topic that the prevalence of epilepsy increased with the severity of intellectual disability, a Canadian group also reviewed 692 patients diagnosed with epilepsy in childhood, and they followed these patients for 20 to 30 years, and 21% of these patients had intellectual disabilities and epilepsy. From them, they classified depends on the severity, and 53% of these patients with epilepsy had severe or profound intellectual disabilities, and 24% they have moderate, and 24 also had mild intellectual disability. So again, as more severe intellectual disability, higher the chance that they will have epilepsy. So in relation to the introduction of the type of seizures, it's important because it could guide also how we can manage and also other strategies. So for example, in cases of focal epilepsy, they are more likely associated with mild intellectual disabilities. In some studies published that 69% they will have focal epilepsy compared to 17% of symptomatic generalized epilepsy. The intelligence is almost normal, not completely normal. But if we move to the symptomatic generalized epilepsy, it's usually more frequently seen in more severe intellectual disability cases, 67%, in opposition of the 29% with more focal epilepsy. So overall, over 30% of people with intellectual disability and epilepsy have symptomatic generalized epilepsy, and usually they don't match a specific syndrome that we can corroborate. So when we move to the more severe epilepsies, we need to talk about developmental encephalopathy and epileptic encephalopathy. So developmental encephalopathy is defined as a static disability that it could get worse over time because it's more evident with the age. And these patients have a higher risk to develop epilepsy, but doesn't mean that they will develop or they have an epileptic encephalopathy. And usually a genetic cause is associated as an etiology of this disease. In the other side, we have epileptic encephalopathy. In these cases, they are characterized by three main things: seizures, epileptiform abnormality in the EEG, as well as developmental regression. So when we talk about seizures, usually they are frequent, they don't respond to the standard treatments. Many of them, they have different types of seizures types, and they could develop what we call a status epilepticus, so these prolonged seizures without recovering, that they are really dangerous, and many cases they need to be brought to the hospital and even admitted to the ICU. So it could be convulsive, non-convulsive, or even combine both. Concerning the findings in the EEG, usually they have frequent, abundant, and really prominent epileptiform abnormalities that it could be even continuous, even if we don't see any clear clinical symptom or seizures. Concerning the regression, it will affect the development, cognition, and also the behavior. And as I said before, most of these epileptic encephalopathies start at infancy or childhood. So the International League Against Epilepsy mentioned that the epileptiform activity itself contributes to the severe cognitive and behavioral impairment beyond what it was expected for the underlying condition or pathology, and also can get worse over time. So in this epileptic encephalopathy, we need to describe that it could be a start from a pre-existing developmental delay, so the kids were already affected. It could also slowly got, it was relatively normal or normal kid, and then when the epilepsy start to get worse and worse. And in other cases, it could suddenly start really abrupt the epilepsy, and then there is a severe decline. So in addition to all these problems, also many of these patients with intellectual disability live in institutions. Growers published a paper that also described that the mortality rate in this population is higher. The life expectancy is almost 20 years shorter than general population, and epilepsy represents almost 4% of the death in this population. So when we move on to now, we suspect they have epilepsy, but what we need to do to really verify this. So epilepsy has a clinical diagnosis. That means that if we hear the history, some risk factors that could be compatible, we don't need to wait for the test to start someone in medication or to call them that they have epilepsy. However, the other complementary tests are important to learn a bit more why they have epilepsy, or other possible etiologies or other treatments that could help. So when we talk about neuroimaging, CT scan, MRI are the standard techniques. However, we highly encourage to use MRI to have a better definition of the brain. When we move on to EEG, there are different types of techniques that we can use. Usually it depends on the duration. The routine EEG is around 30 minutes. Then we can use the prolonged EEG, it could be around 3 hours. Then we can use sleep-deprived EEGs. That's to try to kind of force the patients to sleep while they are having the EEG, and then we can learn a bit more what happened during their own sleep. And then we have the prolonged monitorization or epilepsy monitoring unit that I will just shortly after this explain a bit more in detail. Then genetic, as previously mentioned by Dr. Fried, it's an important modality of diagnosis. So we can use single gene panels, whole exome sequencing, or other techniques. As well, the next step could be metabolic. So moving on to epilepsy diagnosis, we know that these patients with intellectual disability, they have a typical presentation of epilepsy. And sometimes it's really hard to distinguish what is ictal or seizure, what is paroxysmal event, or what is motor stereotypic signs, that until we don't see with EEG, sometimes we are not sure about what is what. So in addition to all that, many of these patients associate autistic spectrum disorder. They could have auditory, visual, or motor impairments that difficult communication. They could associate also multiple physical problems, also stereotypical and challenging behaviors, side effects from other medication, including psychotropic medication, other comorbidities, and in some cases also the supervision, that it could change time to time, or they live in group homes that they are not used to seizures, or they are a newer staff. So it's really important that all these factors could trigger a misdiagnosis in these patients. So, and this misdiagnosis and erroneous diagnosis can also impact in the treatment and how we manage these patients and how they can even decline faster than we were expecting. So, as I said before, they have a higher risk of misdiagnosis, especially if they live in institution. Clinical features may be due to epileptic or also triggered by seizure, and they express in a different way, or we are not used to that way. This mixed behavior could add a new anti-seizure medication, but we can question if it's not effective because probably we are not treating the right thing. Or also we should discuss the polytherapy, just adding or increasing dose without clear explanation or analyzing each case. So misdiagnosis can associate a poor outcome, including higher mortality and morbidity rates. So for that reason, we encourage to reassess when we have a suspicion with one of our colleagues in the epileptologist and try to bring these patients to the epilepsy monitoring unit. This epilepsy monitoring unit has been available in large teaching centers in Canada for many years, and they are especially useful to diagnose what is epileptic, what is not epileptic, or other type of events. So when we need to refer patients to the epilepsy monitoring unit, so when the seizures became uncontrolled, we try different medications and none of them work. When we have a suspicion if these events are really representing seizures, psychogenic events, behavioral side effects, or even cardiac problems, as well sometimes to classify what we are really facing, if it's a focal, generalized. All this will help us to have a better diagnosis, offer other treatments, as well offer other strategies, including pre-surgical investigation, to try to manage their epilepsy in a different way, not just with medications. So in relation to that, with a group of colleagues, we have the question is, how often patients with intellectual disabilities and epilepsy who lives in group homes are misdiagnosed? And we wanted to classify if these patients admitted to the epilepsy monitoring unit, they have epileptic events, non-epileptic, or they have the combination of those. So we decided to review from 2014 to 2016 to see how many times we misdiagnose or what we can obtain from this information. So we published a paper regarding that. So we analyzed 1,122 patients admitted to the unit, and 22 fulfill the criteria of intellectual disabilities, living group home, and suspicion of epilepsy. And at day of admission by caregivers, we found that 36% of them, they were having daily seizures. So try to remember that number, because after I will mention a few more details about that. So from these 22 patients, 12 of these were admitted because the seizures were not controlled. In another 6% of 6 patients, there was a suspicion if they were behavioral or there were seizures. And in other type, in the 4 of the rest, they were admitted because they had a suspicion of epilepsy, but they started with new type of events that no one was really sure what was happening. So in addition to that, we need to consider that more than 0.5% of this sample were not able to communicate properly. So it's really hard to express and to learn more. So in epilepsy, we like to learn what they feel, how they feel. So it's all, this information is obtained by the caregivers in most of these cases. So in summary of this study, the average day, it was relatively short admission. Usually in 6 days, they were discharged, sometimes longer if we were adjusting medication. And then 63% of these patients had more seizures than expected. And compared to what we hear at the beginning, almost 82% of these patients were having daily seizures captured in the epilepsy monitoring unit. So from the total of patients admitted, almost 73% of them, they have only seizures. Around 18%, they have seizures and behavioral episodes, and only 2 of all the total admission, they have only behavioral. So that's kind of reflect the reality, how difficult it is to express, and how difficult or how easy it is to misdiagnose epilepsy or epileptic events compared to behavioral. So as previously described, genetic is an important test, especially in patients with intellectual disabilities and epilepsy. With this test, we can have immediate impact on the diagnosis, treatment, as well as prognosis of these patients. Can also identify preventable or treatable comorbidities that we were not aware that these patients could associate. Can inform about the family of genetic counseling in case that they are planning to have another kid, or if the relatives are going to have kids. Also can provide explanation of relieves the guilt. This is relatively often seen, that why my kid has this, why associate all that. So it's really important kind of try to explain that there is something else than just the fault of the parents, right? So also it's, in addition to that, even if sometimes we cannot treat the condition per se, could also try to put in contact with other syndrome-specific advocacy groups that can teach or help all together to learn more about this condition. So again, I'm not going to go too much in deep about the metabolic investigation. I'm an adult epileptologist, so I'm not commonly see metabolic problems because most of them are diagnosed in childhood. However, we always need to keep the mind open for other etiologies not previously described. So usually with urine or blood, identify 60% of all these abnormalities. But in some cases, when this is negative and there is a high suspicion, sending to the geneticists or metabolic specialist can help to narrow down if we are really treating about this metabolic disorder. So if we try to summarize all that say before, we need to know also that epilepsy is a chronic condition. In most of the cases, they will take medication for all their lives. And also a standardized mortality rate is also higher in patients with intellectual disability compared to other groups. And on top of that, most of these patients will live in institution, and that mortality rate is even higher. So later propose some explanation, including the coexistence of comorbidities could increase the rate to the high rate of mortality, also the higher rate of higher risk of SUDEP, and also having less supervision compared to patients who live at home may affect also the risk of higher mortality. So we cannot talk about mortality in epilepsy without talking about sudden and unexpected in epilepsy. That is the most common cause of death in patients with epilepsy. So in the past, there were proposed many factors associated with SUDEP, including uncontrolled seizures, subtherapeutic levels of anti-seizure medication, structural brain damage, concurrent psychotropic medications, nocturnal or early morning seizures, high frequency of seizures, early onset of epilepsy, frequent medication changes, non-compliance, poor adherence, as well as low IQ. As you can imagine, many of these boxes are checked by our patients with intellectual disability and epilepsy. More recent papers suggest that only frequent generalized tonic-clonic seizures, nocturnal seizures with sleeping alone are factors to increase the risk of SUDEP. However, there is a lot of unknown about SUDEP, and further studies need to be done just to verify or clear risk factors for SUDEP. So after listening all these, what we can do to our patients. So to start the management, we always start with anti-seizure medication unless we have a specific a metabolic disorder, we can't directly trigger that way, but in many cases we use anti-seizure medications. We have a lot of anti-seizure medications, and in the last 20 years, it kind of significantly increased the number. Unfortunately, all of them, they have some type of side effects. As newer they are, less long-term side effects. However, not everyone tolerates the same medication, and we don't have that magic ball that we know which medication is going to work well for each patient, and they are not going to develop any side effects. So we always need to balance between seizure control and side effects. So concerning seizure control, with that we try to minimize the number of seizures for sure. Then we want to minimize the risk of SUDEP, status epilepticus, hospitalization, injuries, affect the development. So, but in the other side, when we add too many medications, we know that they can affect the cognition, behavior, coordination, and other common side effects that we usually see when we use anti-seizure medications. Ideally, we need to focus, choose the medication targeting the underlying syndrome. For example, if they have focal epilepsy, we should use something that works well with focal epilepsy. But also, we should avoid use anti-seizure medications that was tried in the past and didn't work well. So, but as I mentioned before, many patients do not respond to anti-seizure medications, and we call medically resistant epilepsy when they fail at least 2 anti-seizure medications in appropriate trial. Usually, we found that 30% of patients with focal epilepsy don't respond to anti-seizure medication, and 5 to 10% of patients with generalized epilepsy do not respond to medications. But in cases with intellectual disability, even 14% with mild intellectual disability don't respond, and up to 55% of more severe intellectual disabilities won't respond to normal anti-seizure medication. So this is even significantly higher than what we see in general population. So in these cases, we know that this medically resistant epilepsy has increased risk of SUDEP, status epilepticus, polypharmacy, seizure complication, frequent visits to emergency, hospitalization, healthcare costs. And all these poor seizure control could affect the quality of life, and also will have a direct complications from the disease of the seizures, as well as of the treatment, because sometimes with the side effects of the medication, we can make the things a bit worse. So in these cases, our first thought is always try to find a specific region in the brain that we can resect, and then we can control the seizures, what we call resective epilepsy surgery. But to be candidate for that, we need to be able to identify a specific focus, usually small, that we can resect, and this focus will not overlap with any eloquent cortex. However, we have the opposite. Many patients have bilateral multifocal focus. They could affect an eloquent cortex, or sometimes it's so diffuse that we cannot pinpoint one specific region. So in these cases, we need to think about outside of the standard, and we need to propose other alternatives. For example, palliative surgeries, neuromodulation, ketogenic diet, trials with experimental anti-seizure drugs that could try to help. So as I briefly mentioned, epilepsy surgery, try to identify a specific region in the brain, and with some pre-surgical investigation, including MRI, epilepsy monitoring unit capturing seizures, as well neuropsychological investigation, sometimes with other modalities of neuroimaging, we're trying to pinpoint that area. Unfortunately, not in all the cases is possible, and sometimes we go to invasive techniques, including implantation electrodes inside the brain, as we can see in this image, to try to localize specific regions with some specific activity if we can identify the onset of the seizures, and then try to resect that area. So the idea is curative with epilepsy surgery. We have different techniques: lobectomies, lesionectomies, laser ablation, hemispherotomies, disconnection procedure. However, in some cases, this is not possible, and we need to try to offer some palliative treatment, including corpus callosotomy or palliative lobectomies. So if we move to the next step of other treatments, we have neuromodulation. Neuromodulation is a technique that provides some electrical activity in some specific region of the central nervous system to try to modulate and change the epileptiform activity. So the most commonly used is the vagus nerve stimulation. This is similar to a pacemaker. It's implanted in the left side of the chest, and the lead goes to the left side of the neck. And with that, through the vagus nerve, we try to modulate the activity in the brain. With this, we can obtain up to 68% of seizure reduction. It's not a curative treatment, but we try to minimize the number of seizures. Other technique is the responsive neurostimulation. Unfortunately, this is not available in Canada. And with this technique, we implant inside of the brain with some specific regions, targeting where we suspect that the seizures were coming. And with that, again, we can stimulate to try to control the seizure, but also we can store its information of the activity. There are some results that shows that up to 70% of seizure reduction, but for now we need to wait until we get the approval. And then we have finally deep brain stimulation. In this case, we also implant electrodes inside the brain, targeting the anterior nucleus of the thalamus or the central median nucleus of the thalamus, and with the same goal to try to modulate the epileptic activity and try to minimize the number of seizures. So some studies show that at 1 year it's around 43% seizure reduction, and when we go to 5 years, it's around 68%. So just a few more words about the vagus nerve stimulation, because it's relatively common. And we found in our series that 56% of our patients will have at least 50% of seizure reduction. And from these 70%, 65 of these will have at least 75% of seizure reduction. And in overall, as mentioned before, it's around 68% of seizure rate reduction. So we complete a study also in our center, analyzing the response of the vagus nerve, comparing patients with genetic generalized epilepsy, that they don't have any intellectual disability, compared to Lennox-Gastaut. It's one severe epileptic encephalopathy that they associate intellectual disability. They have a higher number of history of status epilepticus, higher number of total seizures, as well as more generalized and more severe seizures. So we found that the response in this, comparing these two groups, that the response rate, it was not as good in Lennox-Gastaut compared to genetic generalized. However, as I mentioned before, the idea with the vagus nerve is to minimize the generalized tonic-clonic seizures or the big seizures, as well as the total number of seizures, as well as minimize the complication, and if possible, the associated anti-seizure medications to avoid toxicity as well as long-term side effects. So they will continue with anti-seizure medication, but we hope to adjust and don't require so high doses. Talking a bit the comparison between a corpus callosotomy versus vagus nerve stimulation, it was published a paper in 2006 and tried to compare patients who underwent only to corpus callosotomy versus VNS or both. And also they evaluate the seizure response as well as the complications associated with both techniques. So as you can imagine, the seizure reduction rate was better in the group of corpus callosotomy than the VNS. Sometimes we're more close in, for example, in tonic-atonic, the 50% reduction was achieved in 78 compared to 67 in the VNS. However, when we compare both techniques together, only in 3 cases there was 80% of seizure reduction. But against that, we have that the frequency of complication is significantly higher in corpus callosotomy than VNS. They are more severe, and also in almost 4% of these cases, it was permanent, the complication. So moving on to other strategies, we need to talk about dietary therapies. It's usually a coadjuvant treatment. It requires to keep with the anti-seizure medication. It requires to be done by a specialized program. Atkins or modified with lower protein percentage could be an option. It's easier in children because they eat without too much problem. They don't have other comorbidities. In adults, it's a bit more challenge. And also we can use this using through G-tube, but even in cases that we have in the ICU, we can administer this to try to modify the status epilepticus. So a common or a hot topic that we have is the cannabis. We have unfortunately limited information. The cannabis and derivatives can have some good results in some types of epilepsy, especially in children with Lennox-Gastaut, Dravet, 2 syndrome. However, we need to consider this as another anti-seizure medication, so they have also side effects. They can interact. The seizure freedom rate is around 8.5%, so it's relatively low, similar to what we found with other anti-seizure medication. And unfortunately, we don't have any medication approved in Canada, so usually we use the cannabis oil or CBD oil, but we don't have the PDOLX, that is the drug that we can use for seizures. So moving to the last part of my talk, it's about comorbidities and complications. I think I'm not the most expert at talking about psychiatric and other comorbidities in these patients that are commonly seen in other clinics. But just to summarize that these patients, they have epilepsy that could be associated with some underlying anxiety, mood disorders, psychosis, HDAD. On top of that, we add some anti-seizure medication. On top of that, they might have underlying neurological conditions that make everything worse, as well all the stress and everything that is surrounding to these patients. Especially now with COVID, many of these patients, they are really struggling because being at home so many hours, not to be interacting with the other, is really affecting their lives. So finally, like SUDEP, it's a really critical topic that need to be discussed in clinic. We try to find all the measures that we can minimize. So supervision during the night, it's something that could associate with a reduced risk of SUDEP in these patients. There are some studies that say that because most of the patients found with SUDEP, they were in prone position. So some seizure monitor that can alarm caregivers could also be helpful. Some VNS now, they have also the devices that can tell you if the patient is in prone position, just to learn more about other strategies. So, and something that is not commonly discussed in our in general, but it's part of our clinics, is other strategies that is not medications or other surgeries, other more complicated topics, is about just communication. Establish a good communication between parents, patients, caregivers, physicians, emergency, that everyone is in the same page, that we don't change medication if it's not strictly necessary, that we don't order tests if it's not necessary because it causes stress, and if it's not necessary, why we need to do that. So also it's important to think about the caregivers. They have a higher risk to burn out. Some of these patients, they are getting old, especially in my case, that I'm adult, and the parents can still take care of these patients, but they have complicated, including behavioral seizures, that they feel overwhelmed, and if they don't have resources, can cause really severe or high impact in patients as well as the caregivers. I usually establish a seizure emergency protocol every time that comes to clinic, just to review what they need to do if the seizure happens. If it's less than 2 minutes, we put in the safe position. If it's longer, we can give lorazepam, and when we need to call to emergency, just to avoid unnecessary visits to emergency. Also, we need to think that these patients should receive some special treatment, because if they are admitted to the hospital, perhaps, and they are alone, no one is visiting, they can be even worse, getting worse, even without getting worse as that condition. It's just they need the interaction. And then finally, a transition epilepsy program, especially in patients with intellectual disabilities and epilepsies, is a key point to facilitate a good management. So we have or know before you go. So transition, it's serious, the problem, when we don't have a established program from the pediatric to the adult world. Some studies mention that up to 50% of cases fell to the crack and they don't arrive to the adult world. And this lack of follow-up can have a direct impact in non-adherence to treatment or in inconsistent medication, because no one is following, no one is really looking after this, and also complications in young patients, and increasing even more the mortality and morbidity in this group. So transfer is just giving the charge to someone, to the adult, and transition is the process that we prepare the patient and the families, what they need to do, what they need to get ready before they move to the adults, and how this process will take place. So in transition clinic has been associated with many chronic disease. However, in epilepsy, we opened recently on 2019 or clinic Know Before You Go, just to help with an organized and structured process with collaboration between different specialties, including the caregivers, the family, the patients, the adult and pediatric epileptologists, the epilepsy nurse, the transition specialist, to make possible a smooth transition from the pediatric program to the adult epilepsy one. So this is the current team that we have for transition clinic. And just to summarize everything that I have been discussing through all these minutes, so intellectual disabilities and epilepsy is a frequent combination. Seizures are usually difficult to identify and frequently underestimated. In many cases, they require many anti-seizure medications, and this could be associated with increase of the risk of side effects. Intellectual disability and epilepsy increase the rate of morbidity as well as mortality. Epilepsy requires a complete investigation. Even in some cases, other therapies, not because they have intellectual disabilities, we cannot offer more invasive therapies to control their seizures. And intellectual disability and epilepsy require a multidisciplinary team to manage their seizures as well as the other comorbidities that sometimes affect almost as well as the seizures. So I will take any questions that anyone has.
Thank you, Anna. That was great. I mean, it was wonderful, actually, and a really nice overview of epilepsy and the difficulties we see in this population. We have lots of time for questions, but let me start because I've got about 1,000. So, I mean, first of all, and I might have missed this, but do you think there's sort of a hierarchy in terms of medications, anticonvulsants that are going to cause behavioral problems? Do you think there's a hierarchy in terms of which are the most likely and which are the least likely?
Yeah, when we know that the patient, one of the questions that we always ask in clinic is, how is the mood? Because depression, behavioral problems are a big challenge. So there are, for example, levetiracetam or brivaracetam or perampanel are highly could cause this. So we always need to go away of this medication. For example, lamotrigine, unexpected, but sometimes has the paradoxic effect that instead to help, it causes more mood or even a change of behavior. So we always need to discuss with patients in clinic and caregivers that we are starting this medication. It could happen something. So in that case, you need to notify. So changing medication is not just because they don't respond, also to if they develop side effects, because if they develop side effects and they don't take the medication or they don't give the medication, we are in the same spot. So, yeah.
I don't know if it's right to say I'm glad to hear you say that, but certainly, over the years, that Keppra is certainly the medicine I think I've seen that has caused the most behavioral problems with kids. So I'm glad it's not just me.
No, no.
All right. Questions from other people. So there is, so Rhonda Peterson is a psychologist at CPRI, and her question is, what in the epilepsy unit, what do you guys use in order to formally diagnose intellectual disability?
So we don't diagnose with intellectual disability in the unit. We have our clinical psychology, neuropsychological team, but with the unit, we try to identify what was called misdiagnosed. So we put the electrodes on top of the head and we try to capture the events or the suspicion for events when they were at home and try to see the correlation between the events and the EEG changes. Try to think that if they are seizures or they are not. Imagine if there are no changes in the EEG, we suspect that they are not seizures, and then we need to treat in a different way. Perhaps we need to ask if adjust some of the psychiatric medication, or perhaps the patients, they have side effects and then they are not able to explain properly what they feel and they start to do some peculiar movements. So then we need to adjust also anti-seizure medication, perhaps some behavioral issues going on.
So to answer Rhonda's question then, so any assessments around cognitive ability or intellectual disability diagnosis, that would be done by the team psychologist or neuropsychologist?
Yeah, it depends the collaboration of the patient, right? If they are more severely impaired, we cannot do too many tests, but if they are relatively okay, that they can complete some forms, that they can be tested, we can have a overall assessment of what is going on. So usually most of these patients, they have already the diagnosis, but we just kind of adjust the other things around the epilepsy.
So I mean, and Ron, to answer your question, my end, you know, in having seen a few assessments anyway from psychologists here at the hospital, they would use sort of standard the WISC or things like that, or the Stanford Binet. All right, so Dr. Ogilvie has a question, although now I cannot see her. Hand raised. It was raised a second ago. Oh, there she is. All right, Jackie.
Hi, that's great overview. Thanks so much. Could you talk a little bit more about those terms, developmental encephalopathy? Are these findings on EEG plus a developmental profile? Like, what defines what to call something a developmental encephalopathy, and what would we expect as developmental pediatricians of that underlying EEG? Because I sometimes struggle with when I see epileptic encephalopathy making diagnosis, and then I get asked, does this child have autism? Trying to know what the underlying neurology is and what their course would be, separating what might be static from progressive. Be just helpful to know a little bit more about those two things.
So yeah, that's a great question. So developmental encephalopathy usually doesn't associate seizures or epilepsy. So they have a higher risk to develop and they move to another category, but per se, this group don't have epilepsy. And then we have the epileptic encephalopathy that they usually have a severe epilepsy, hard to control, and they also associate the intellectual or developmental disabilities. I don't know if that helps or...
So to call something a developmental encephalopathy, but they don't have seizures, is that an EEG finding then?
In the EEG, we can see slowing, but nothing specific to identify that they have epilepsy. However, you need to keep an eye always in these patients because the lack of communication skills that maybe they are not able to express and maybe they are having seizure and we are not aware. But developmental encephalopathy doesn't imply that they have epilepsy. They don't have epilepsy.
Okay.
So then you need to assess in a different way, perhaps to assess if it's a more autistic spectrum or other issues, but they don't have per se epileptic abnormalities in the EEG, and they don't have per se epilepsy. However, as I say, they can move categories pretty fast.
Okay, thank you.
You're welcome.
So another question that comes up quite a lot, I think, Dr. Suller-Marti, is around, you know, people with epilepsy and significant behavioral problems and cognitive disabilities. And, you know, when should we worry about starting psychiatric medicines and the risk of worsening seizures?
So I think patients with epilepsies are really complicated package because they have almost everything together. But we treat patients with antipsychotic medications like olanzapine, risperidone, because at the end, if we don't treat the behavioral problems, they can injure themselves, they can injure someone. So we are not scared to start antidepressant medication or even antipsychotic because at the end, it's kind of balanced all together. So we use alloperidol, sometimes olanzapine, risperidone. So when it's needed, we need to start and just go ahead. So
because I have a patient who had surgery a couple of years ago, and I think it had really sort of intractable seizures before that, and it's been doing great since then. But first of all, developed pretty severe OCD, and more recently clearly has ADHD. And so her mom and I had talked to a couple people, and I think there were a couple of large reviews from, I don't know if it was the Epilepsy League or somebody else, basically saying that methylphenidate anyway is probably reasonably safe in people with epilepsy. I mean, would you agree with that?
Yeah, like our patients have other comorbidities, like not just the intellectual disability, but with other things, and we need to just adjust. And at the end, every patient responds a different way. Some are more sensitive, some other are less. So that's a good topic because usually before any surgical resection, we try to do a neuropsychological assessment, including mood, because if they have already a predisposition to have some worsening of the mood, after surgery is going to get significantly worse. So sometimes even if they are good candidates for surgery because of the comorbidities, including the severe depression, we should not offer surgery to try to avoid other problems. We stop seizures, they don't have epilepsy at that point, but we have all the other complications that sometimes is almost as bad as the other, as just having seizures.
Yeah, I think when this girl first started having OCD symptoms, I think they were pretty disabling actually for her. Like, it was really difficult to get her to even leave the house because she was just straightening things and washing her hands so much every day.
Yeah.
All right, other questions for Dr. Suller-Marti? So certainly, and if people have questions, they can sort of ask them in the chat or by Q&A.